Welcome to another episode of Numbers in Medicine. Today we will discuss Anion Gap Metabolic Acidosis. At the top you'll see the equation that relates the concentration of bicarb and the partial pressure of CO2 to the pH in the blood. That's our Henderson-Hasselbalch equation. And in the table you'll see the four major kinds of acid-base disturbances we discussed in the last video. Today we will focus on metabolic acidosis, where the bicarb is decreased. This is another framework for how to evaluate the four major kinds of acid-base disturbances. You start with an arterial blood gas, and the pH should be between 7.35 and 7.45. If less than that, then you're thinking acidosis, and if greater than that, you're thinking alkalosis. For our acidotic processes, it can be metabolic or respiratory in nature. If the bicarb is low, less than 24, then think metabolic acidosis. If the PaCO2 is greater than 40, think respiratory acidosis. And then for our alkalotic processes, if our bicarb is elevated, greater than 24, think metabolic alkalosis. And if our PaCO2 is low, less than 40, then think respiratory alkalosis. A brief, quick, general framework on how to evaluate the four major kinds. Today we'll be discussing metabolic acidosis. There are two major kinds of metabolic acidosis. The first is anion gap metabolic acidosis, and the second is non-anion gap metabolic acidosis, sometimes conveniently called NAGMAs. For anion gap metabolic acidosis, these are typically more dangerous and more life-threatening as opposed to the NAGMAs, which are more benign. We will talk about anion gap metabolic acidosis in this video. First, it's important to define the anion gap. It's equal to the measured cations minus measured anions. Cations positive charge, anions negative charge. In the US, sodium is really the only measured cation we care about, and then chloride and bicarb are the measured anions. In other parts of the world, they'll include potassium in that measured cation group, but it's typically around 4. In theory, doesn't vary too much, so it doesn't affect the anion gap that much either. Thus, it's often ignored in the US. Most of the unmeasured ions are anions, so the anion gap should be positive. And as an equation, it's anion gap equals sodium minus the quantity chloride plus bicarb. A normal anion gap is less than 12. Greater than that, you're thinking this is an elevated anion gap. Now, that number 12, you'll see different numbers elsewhere, somewhere 10, somewhere other numbers. Just depends on the lab, depends on the system. But this is a pretty standard number, which we're going to use for this video. There was a great article in The Lancet around a decade ago or so that offered a new framework for thinking about anion gap metabolic acidosis using the gold mark mnemonic. And it stands for glycols, oxoproline, L-lactate, D-lactate, methanol, acetylsalicylic acid, renal failure, and ultimately ketoacidosis. We'll talk about each of these in a little bit more detail. The first is glycols, mainly ethylene glycol. In recent years, propylene glycol has been a big talking point too because it's used as a diluent in IV medications, but I'd rather focus on ethylene glycol, more common and likely more dangerous. Ethylene glycol is commonly found in automotive fluids like antifreeze. And if you pour antifreeze in a cup, it kind of looks like Gatorade. It can be a bunch of different colors, and sometimes people mistake it for just a regular drink like Gatorade. But of course, it's much more serious because its unmetabolized effects include CNS and GI consequences. They'll become lightheaded, dizzy, have nausea, vomiting. And then once ethylene glycol is metabolized, it causes cardiovascular, respiratory, and renal effects. On the exam, they'll give you some story about ingestion, whether intentionally or unintentionally, or potentially some kind of outbreak at a party. A patient comes in with nausea, vomiting, they're dizzy, then later they develop tachycardia, tachypnea, and ultimately renal failure. And they'll have an elevated anion gap, so an anion gap metabolic acidosis, an elevated osmolar gap, and then calcium oxalate stones. You can see those on the spun urine but also it's those calcium oxalate stones that can cause renal failure. Next is oxoproline. Not much to discuss here, just know that it's associated with chronic acetaminophen use, and it's a more recent discovery of a kind of anion gap metabolic acidosis. Next is L-lactate. This is one of the two major stereoisomers of lactate, and there are two types. Type A, elevated L-lactate, think of shock, essentially overt hypoperfusion to essential organs, as opposed to type B, which is basically everything else. There are many other causes, but think of it mainly in terms of the medications that classically cause it. The teaching used to be metformin, that's debated now, but it really is biguanide that caused this elevated L-lactate. And then other medications include beta agonists, epinephrine, theophylline, linezolid. There's a longer list, but these are some of the main ones. D-lactate is the other stereoisomer, also somewhat recently discovered, or at least grew into prominence. And classically, it's in short bowel syndrome. In short bowel syndrome, you also have alteration of the gut microbiota, which lead to this increased production of D-lactate. Classic exam question. Next is methanol. Methanol is often mistaken for ethanol, or it's a potential contaminant to drinking alcohol, or in some tragic cases, it's a cheap substitute for ethanol. And every so often, you'll hear in the news about a giant outbreak of methanol ingestion or toxicity. Initially, patients develop CNS and GI effects, similar to that of ethylene glycol, and then later, 12 hours or so, often develop visual disturbances or blindness, and that's the clue on an exam that kind of keys you into that this is likely methanol toxicity. So someone went to a party, they develop nausea, vomiting, they're dizzy, and then the next morning they can't see, and this is classic for methanol toxicity. Significant labs include elevated anion gap, so an anion gap metabolic acidosis, and an elevated osmolar gap. Next is acetylsalicylic acid, so I'm thinking aspirin. Patients who ingest large quantities of ASA first will likely develop tachypnea, and it's because their respiratory center in the medulla gets stimulated. So they breathe faster, they're expelling CO2 and develop that respiratory alkalosis. But this is the metabolic acidosis lecture, so I'd be remiss if I didn't discuss that they also develop metabolic acidosis, and they may develop tinnitus, nausea, vomiting, and tachycardia as well. In severe cases, they develop debilitating CNS effects, including seizures, coma, and potentially death. Next is renal failure. Could be a lecture on its own, but it's a vicious cycle. Renal failure can actually lead to anion gap metabolic acidosis, which can then worsen renal function, which can worsen the anion gap. It's a vicious cycle that needs to be addressed relatively early on. And finally, ketoacidosis. There are three major kinds of ketoacidosis. The first is diabetic ketoacidosis. And the criteria include blood glucose greater than 250, ketones in the blood, and pH less than 7.3. It's one of the easier diagnostic criteria to remember, maybe not the number specifically, but these three criteria are in the name. So diabetic, high blood glucose, keto, ketones in the blood, acidosis, pH less than 7.3. Again, you may not remember the numbers, but the framework is easy enough to remember. The other two are starvation ketoacidosis and alcoholic ketoacidosis. This was a very short introduction into anion gap metabolic acidosis. In the next video, we'll focus more on the numbers and kinds of compensation. But for now, this is a good intro to anion gap.